But anyway, I'm going to talk not about eHealth because of the scandals and that. It's more about computers in healthcare and clinical informatics. I mean, actually, one of the things I'm going to be talking about relates to something that Dr. Vicente was bringing up is the lack of user input in the design of many clinical information systems in healthcare and how it's really held us up. But a lot of people will sort of say, you know, how come I can do all these things online these days? You know, book my restaurant, airline tickets, order a book, it's there in 2 seconds. But I go to my doctor's office, first of all, they sometimes don't even have a good answering machine, never mind being able to book online. Same illegible charts they've used for hundreds of years, same crappy prescriptions, and they communicate using these pagers that no one has used, including drug dealers finally abandoned. So the promise of eHealth is that, you know, there should be electronic medical records that would be accessible basically everywhere. I mean, so many times, you know, you talk to patients and it's like, but I told this in my chart, and you have to say, well, you know, your chart's locked in someone's office now, or you know, something like that. Illegible electronic prescriptions. I mean, I'm not going to read it all. There's lots of things you could do with eHealth. So I'm going to just give a few examples of how, in practice, this has turned out to be quite difficult. Talk a little bit maybe about why, and that's probably about all I'll accomplish in 12 to 15 minutes. I mean, this is the famous reason for wanting computers. This is a real example for those of you who are not in healthcare, but even for those of you who are, it is very difficult to tell if that's a prescription for Plendil, Isordil, Zestril, or Inderol. All of them are cardiac-related medications. In fact, it was meant to be for Isordil, it's a type of nitro, but they ended up being prescribed as Plendil, and actually this led to, this is what would be called a clean kill. This was a totally well person who was killed by this error. In this case, the pharmacist and the physician shared equal responsibility because, in fact, 20 milligrams is too high of a dose for Plendil, and so the pharmacist probably should have called. I'll give one last example. Almost every physician who I ask would say this is Coumadin. It's actually Avandia, which is a diabetic medication, and they are actually available in the same dose. So, interestingly, before I go on, so illegible actually there was a study in the BMJ that showed that doctors' handwritings are no worse than engineers, lawyers, and a whole bunch of other people, but we happen to work in an industry where it actually matters. Where it matters that people can read your handwriting, where it matters, not the industry. I mean, that if you have illegible handwriting, you could kill somebody. But what I meant was that in practice, it usually just wastes lots of other people's time. It doesn't kill people. In other words, nurses and pharmacists spend a lot of time trying to decipher a doctor's handwriting, and eventually they'll call if they can't figure it out. So in reality, messy handwriting has actually harmed very few people. It's wasted a lot of time. What's a bit depressing, though, is that these $40 million systems, that's how much they tend to cost per hospital, $40 million, $20 to $40 million per hospital. And most hospitals obviously are operating, well, not at a profit. But actually, they're spending all that money for something that is not going to actually improve care unless they have decision support to go with it. And decision support is the thing that's going to pop up and say they shouldn't be on this medication, they're allergic, or something like that. But we actually just completed a meta-analysis of a lot of trials of these computer reminders and decision support that was published in the Canadian Medical Association Journal. And what we found was that across 32 trials, there was basically a homeopathic improvement in care. That if you're trying to improve the adherence to some guideline, it would improve by 4%. So if you wanted to get more people to be on Lipitor, or fewer people to get antibiotics for unnecessary colds, 4% was the average improvement achieved. There was one hospital in Boston that I happened to have trained at, and we actually did do a nice trial of this that was bigger than all of the other studies, but there was not a single other predictor of what made these reminders work. So until we identify, and we looked at a lot of interesting human factors as well as study design features, there was really no factor that affected whether they were going to succeed. And so right now, basically, this is an expensive case of trial and error to see if you're going to improve things. So, but they're still widely recommended, to the point that in the New England Journal last year there was a big paper emphasizing that only 1.5% of US hospitals have a comprehensive electronic medical record system, maybe 15 to 17% if you sort of do a looser definition. In Canada, I'd say for computerized order entry, there's at most 15 hospitals, not percent, in the whole country that have CPOE. But the interesting thing is that it is actually very difficult to implement. So there's been some reports of major shutdowns, and I was actually talking to Neil, the previous speaker. There was a Wall Street Journal pullout, I think just a few days ago, that mentioned the Cedars-Sinai debacle. So this was a $40 million system that after 1 month they had to shut off because the doctors were so upset with, like, you'd have to go through 40 screens to just order vancomycin. Children's Hospital of Eastern Ontario in Ottawa had a positive study reported in the literature. Actually, there's very few studies that have shown, no study has shown an improvement in patient outcomes from computerized order entry. But they still go ahead. This was one of the ones that at least showed a reduction in errors, even though patient care didn't improve. And when I moved to Ottawa from San Francisco, I said, oh, I'd love to see your computer system. It's like, well, we have to shut it down. There was a concern that it was causing too many new errors. And they actually haven't turned it back on in the last 4 or 5 years. And out of a survey of about 1,000 randomly selected hospitals, 10% of them had some kind of CPOE, and at most of these hospitals it was still only partially implemented, and in about 30% of them they basically just sat there not being used. So why is it hard to implement? I mean, one of the problems is that many of the vendors have basically had no previous clients in healthcare, or maybe one. They sort of were in some other industry and they said, well, how hard can it be to computerize healthcare? The impact on workflow is often ignored, a lot of the things that Dr. Vicente and others would talk about. I'll talk a little bit more about that. High cost, incompatibility with other systems is a huge problem. So the pharmacy system may have been computerized for years, and the new CPOE system doesn't talk to the pharmacy system. You can't stop giving people medications for several months while you try to implement your computer system, or your billing system can't shut down while you try to implement your computer system. And sometimes even when the same company sold you that system, now it still isn't compatible. So there's lots of interesting problems there. I would actually, I'll talk a little bit more about this later, but I mean, there was a factoid going around the informatics world a few years ago that I think the Stanford Hospital SQL server had the same number of transactions a day as the NASDAQ. So in other words, that a single academic hospital had more going on its order entry system, electronic medical record, than the whole National Stock Exchange. I mean, it's a little, the US might be worse than Canada because of the extra layers of bureaucracy related to insurance, but the idea is it is very different. If you just go to the Instabank and stick in your card, it basically just has to verify that this card matches this account, you have enough money, and then it gives you the money. But if you want to give a drug to a patient or a procedure, there's like multiple things that have to go on, interrelated different databases and so on, and you have, often 50 things done to a single patient a day. You may have 500 patients that day in the hospital, and so on and so forth. It is quite a staggering volume of information that has to be exchanged related, and they have to be operated 24/7. I mean, you can order a book on Amazon, but it'll be there in 2 business days. But Mrs. So-and-so needs her hydralazine right now, and if I realize the next minute that I meant to order hydroxyzine and I wanted to cancel it, I have to be able to cancel that in 2 minutes. So there's none of this business about, your money will be in your account the next business day, that type of thing, and it can never go down for maintenance. There's a lot of other issues about why this has proved to be difficult. Interestingly, it also doesn't save time. For nurses, it may save time. For physicians, it almost certainly doesn't save time. Some of it's a case of usability. Some of it is that the quality of documentation can sometimes improve, but at a cost of time that people have not, you weren't used to writing a 20-minute note anymore. You were used to writing, patient looks basically well, their vital signs are stable, and now you have this template-driven thing where you have to enter a certain amount of information. Interestingly, that creates other problems where sometimes the information is no longer organized in a way that people find very usable. There's a bunch of other fascinating problems. Some people copy and paste previous notes, and so now the notes get devoid of any information. People just sort of get this longer and longer note as more and more people copy and paste from previous notes. There's all kinds of interesting problems, but in any case, it doesn't save time. And if you've got a lot of people to write orders for, and it adds any time, that adds up to quite a lot of time over the day. And then there's also this interesting problem that's come to light over the last few years about even creating new errors. This was an interesting qualitative sort of observational study done at the University of Pennsylvania, where they went around observing medical students, residents, and doctors using this system, and they found a bunch of interesting errors. I would say the one error that is probably more common with computers and with regular papers is entering something for the wrong patient, which is of course the worst error. The reason it's more common is that when you have a chart, sometimes you'll realize, wait, this chart's too light to be Mrs. Jones's chart. She's been here for like a year or something, and this chart seems very light, so then you read it and go, oh my gosh, the wrong patient. But if you just have an alphabetic drop-down list and you pick the wrong person, well, all the screens look the same. It can be quite a disaster. In fact, a colleague of mine realized once that they had written an order for the wrong patient, but they had no idea which patient that was. So in any case, that can be a problem. Another interesting problem they noticed with medical students was that they had stopped carrying around the drug reference with doses because they knew that if they just entered a random number, that it would tell them the right dose. But the problem is if you have to enter thousands of doses, sometimes the default dose will be wrong. In fact, there was a case of that at the Boston hospital that I trained at, where they'd entered the default dose as 4 times a day instead of 3 times a day for cefotaxime. And it was only noticed a year later when the pharmacy noticed that their costs for cefotaxime had gone up by 25%. So a lot of times, people will just go with the default dose, so the default dose is wrong, and especially if you've got students using this as their reference, that could be a problem. And there's lots of other problems. Overriding users with alerts. You get so sick of being told, do you really want to give this drug, that you ignore all the alerts. And then, of course, the one time the patient really is having an anaphylactic reaction and you ignore that alert and give them the medication anyway. This was an interesting case of the wrong patient, where one of the nice things about computer order entry is that the residents can order drugs from their call room. And so someone ordered vecuronium, which is a muscle paralytic agent, on a ward patient. It was supposed to be an ICU patient. So this is a drug, it's basically based on curare, the poison darts and all the old movies that someone in South America or whatever, the Amazon. So curare-based agents that poison people's muscles. And so basically a ward patient got this, and amazing, the patient was, interestingly, the nurses verified the dose and the pump settings and did all the stuff they're supposed to do, but for the wrong patient. The patient collapsed on his way to the bathroom, was able to call for help. Unfortunately, the nurse said, do you think it could be the medication that I just hung? And they realized what the problem was. So a lot of times, a new innovation will create new problems, and computers are, no exception. I'll give a personal example from, I'm on the wards right now, and this just happened. So we have this e-discharge program. I mean, discharge summaries at hospitals have been notoriously terrible. There are some, whether they're dictated by the students, the residents, or the staff, they're almost always terrible for different reasons. The students, because they don't really know maybe what they're supposed to be doing, and the staff, because by the time they get to it, they've got a list of 30, and they no longer care anymore, and they don't really remember the patient from last month. So there's a lot of problems to be solved. And so it's a reasonable goal to have this e-discharge program where you're going to have a template that you're going to more or less force the doctors to fill out at the time of discharge. And there was a documented improvement in the turnaround from a median of 13 days to 1 day, which is fantastic. But there's a lot of interesting problems and usability issues. I would say anecdotally, as somebody who really tries to use this and really go out of my way to communicate well, one of the things I found actually since moving back to Canada is that we do a terrible job in the hospitals of talking to the outside doctors. So in any case, this guy came from a seniors residence. He's on a lot of medications. There were some important medication changes made, and this is what happened. So he gets this thing, it says, new medications to be taken. It lists all these medications. But then the medications to be stopped are more or less the same. A whole bunch of them are the same. Some of them are the same drug, but one of them is the brand name and one of them is a generic. So I got paged really angrily by this doctor, and I felt terrible because I'd actually spent hours with this patient, and including on this discharge summary, and I even had to write, so this supposedly time and quality saving device now has cost me first an angry phone call from the family doctor, then I had to rush to my office and basically write this long letter to him and clarify an addendum and figure out a way of getting it DPR. And basically, as I explained in my letter and in my conversation, that it's very, again, it was intended for the right reason. This thing called medication reconciliation, of figuring out what patients used to be on, what you want them on now, and making it very clear for the family doctor what they're supposed to be on, so that everything matches up. But the problem is it's a very difficult to use system, so it's much easier for the residents to simply stop all their old drugs and restart them at the new doses. And so everything, but that means that everything shows up as a stop taking Lasix. Oh, new drug, Lasix. Stop taking Lipitor. Oh, new drug, Lipitor, right? And so, and actually there were so many of them that there were in fact a few legitimate oversights that I actually had to correct as well. So I got just a couple minutes left. So this is the last thing I was going to say is, this is another local example, but actually from the hospital I trained at Boston, this was initially like the wave of the future. They were paging people, do I have them? What they have is critical labs, like if someone's sodium is really low or they have a positive blood culture, typically what has to happen is you have to phone the resident maybe and say your patient is whatever, got this problem. And it often takes a while to find the resident, and then by the time the resident figures out what to do, like a long time may go by. So they said, we're just going to instantly have the lab page with a text message, sodium equals 115, right? So this seemed to be great in this study for Brigham and Women's Hospital, and so we tried to replicate it here. But the first thing is there's a sort of a saying, if you have an automatic system and it's broken, you have an automatic broken system, right? If you automate a broken system, you have an automatic broken system. So if you're sending pages to people, you better be sure it's the right people, right? So first we did a study and showed that 15% of all pages are sent to the wrong doctor, and about half of them are emergency situations, like come and assess this patient's breathing, but they're actually on vacation. Or they're post-call asleep and they have their pager off. So first there was this incredible like year-long effort, and it involved one of the clinical associates, basically a junior faculty member, manually making sure everyone had the right pages just to set up for this project. And then when they did a randomized controlled trial of this, they basically did find an improvement, but it was not significant. So after all the effort they had to go to even set up for this new innovation of having the critical labs go to the people, first they had to go to all this effort to make sure that the right people were being paged, and then still there was this only a non-significant improvement. This was a randomized trial that just got published this month. So basically this stuff is hard. It turns out to be just as hard as like regular science. Like it's like you'd think, oh, quality problems, just sort of like computerize it, automate it, and we'll fix it. It's not the same thing as discovering a new drug, but it does turn out that these things are very difficult and it's incremental steps. And I guess just worth remembering that many big IT projects fail in other industries, and some of the performance requirements that I mentioned before that make healthcare a little bit different, maybe more like a nuclear power plant than maybe just any old business where you really need to be up and running all the time. And then I guess lastly, I'll just say that I mean, the successful IT projects at institutions that have done well tend to have had homegrown systems with a lot of healthcare professional input. A little bit, again, like what Dr. Vicente was saying, the nurses were so surprised that anyone was asking them. And that actually clinical informatics is already a pretty large, well, it's a growing field in the US. And I think that it's going to be, like you hear about, you know, clinician educators, clinician researchers, they're clinician administrators, like encouraging more doctors and nurses to get MBAs. I mean, informatics is going to be a big field, I think, in the future. And you already get some people interested in that. There's some major centers in the US. I mean, the U of T is starting to build a program because I think we really need people both on the innovation side, but even the maintenance side. At most healthcare settings will need a health professional who's really plugged into the informatics. Thanks very much.